For this session, we have about, we'll break it into three components. The first component will be about hearing stories about what practitioners have been doing, what has worked for them after a training they had. That will be the first component. The second component would be now looking at practitioners at institutional level. So what has worked for them? What lessons can we draw from their experiences? And the final session will be at policy level, looking at county and national level and exploring the same question. What is working in terms of looking at quality across the entire health system blocks? The reasoning behind this is that every so often the conversation has been centered on quality from a service delivery perspective and quality from an information monitoring perspective. But the reality is that there are other components, whether it's human resources for health, whether it is commodities and products, whether it is financing, whether it is leadership and governance. Where is the interplay of all this so that it funnels down towards quality and patient safety? So that's a conversation we're going to be having today. And as I'd mentioned, we will have three components to this conversation. And to start us off, I want to invite my first set of discussants. Yeah? And these are alumni of the Acquire IHI Quality and Patient Safety Training. It was a virtual session. I think there were about 700 participants across 10 countries, but we have a few representatives present here. To start us off, and I'll ask them to come, and I'll give you a brief of who they are, their profile, as I introduce them. So the first one on stage will be Chris Mandere from Kijabe Hospital. So Chris is a highly motivated, results-oriented nurse officer, over 8 years of experience. Should be clapping for him as he just, yeah. And 5 years in senior leadership positions, has proven ability to champion operational excellence and process improvement. We will want to hear from him this proven ability to champion. How has it looked like? And how has that been anchored on the training that they had? Yes. So thank you very much, and karibu sana. Second on stage is Dr. Ndi Nora Nya. So she's a medical doctor, internist, and chief medical officer at Mbingo Baptist Hospital in Cameroon. She's also an assistant program director at the Christian Internal Medicine Specialization, Bingo Baptist Hospital. An associate professor with voluntary status at the Loma Linda University in California, and a board member of the Christian Academy of African Physicians. Ladies and gentlemen, a round of applause for Dr. Ndi. Third on stage would be Dr. Edna Oje, a seasoned consultant pediatrician with a passion for child health, advocacy, research, and medical education. Currently attached at the Mbagathi County Hospital and as a lecturer at the Department of Pediatrics and Child Health in the University of Nairobi. Also very passionate about mentorship. We'd want to see and listen from them about their experiences around this quality journey, the training they had, and the impact it has had at their respective places of work. And in the order in which they appeared on stage, I'd want to throw the first question to Chris. Tell us about your story and how the training impacted you and impacted your work in quality at Kijabe.
Thank you so much. Good afternoon. It's afternoon, I think. I left there 2 minutes before afternoon, so it's afternoon. The journey to quality, where I work specifically in Kijabe Hospital, which is a level 5 hospital, taking care of patients from different places in Kenya, even from some of our countries, the countries represented here. It has not been easy. It has been a journey over several years. Back from 2019, 2020, when a smaller team thought of quality improvement, they had enrolled on IHI programs and undergone training. But some of us came to learn about quality improvement through what they were doing. We looked at systems that were broken. We always had patients who were not delighted with the services that we're giving out. Like an example of if you went to a hospital in the morning at 5 a.m. and then leaving the hospital at 11 p.m. in the evening, how do you feel as a patient? And then asking ourselves, is this really what we want for our patients? No. So smaller teams led by Dr. Mary Adams, Professor Mary Adams, came together. Some of us were nurses, and nursing, actually, we came on board later. I think we didn't know that we really needed to improve it, but through the team that was there, we now started talking about quality improvement, looking at processes. We were approached by different teams to get on board on quality matters. We got on board, and I can tell you that the changes we've had in Kijabe are tremendous. We've improved and engineered several processes that have made our patients happier. We have inculcated a culture of talking quality, a culture of a positive culture on how do we improve our care. If I did something that's not right as a nurse, how do I report it without feeling like I'll be questioned for the same? For example, if I gave the wrong drug to a patient, will I fear talking about it because I'll be punished for the same? A positive culture of looking at the system. And so I can say that IHI, and I came to do IHI later, not actually a few weeks ago, but now looking at what I got from the training and what we've been doing, for sure, culture improvement is a key component in getting all the systems right. So you benefited from it, and it's working for us in Kijabe. That's all I say.
Thank you very much for highlighting the role of culture. In my other life, I do a lot of financing and economics, and in policy, we argue from a rational point of view. But the reality is that people are first human before they are rational. And appealing to that human nature is what he has spoken to. Positive culture change, and that then becomes important in driving quality improvement. And he draws a parallel from the experience he's had in the training and the confidence it has given him and his teams towards speaking and driving quality improvement in Kijabe. We'll get back to you, but thank you very much. Dr. Ndi, how has your experience been, both as a participant and then also as an implementer on the ground on quality improvement?
Thank you very much, moderator. Good afternoon, everyone. Yeah, it's a privilege for me to share my experience from the IHI Open School. First of all, I want to apologize. I caught a cold, so I might not be very audible, but I will try my best. It's affecting my voice. Having been practicing for over a decade, I have had my concepts about quality. I serve with the Cameroon Baptist Convention Health Services, and our vision statement is summarized in 4 words: quality health care to all. And I realized that every healthcare provider has their concepts about quality. And everyone has been trying to do what they can do to the best of their capability to push forward quality care in the institution. It was until February this year that we learned about the quality improvement course. The Acquire team reached out to us. And I was wondering, what are they going to talk about? Do they want to give us the latest developments in medicine? Because my understanding has been that for us to offer quality care, we have to be up to date on the latest developments in medicine as a medical practitioner. And I mean, that's what we preach every day. As a doctor, you have to be up to date. Things are changing. As a nurse, you have to be up to date to be able to give quality care to patients. This is important. But when I started the course with Acquire, I realized that this is just a single component of quality that we are talking about, and a lot is embedded into it. And it was really an eye-opener for us, because there are many important aspects of quality healthcare that we have been ignoring and that we have to bring on the table at this point. I will just cite a few aspects. In my practice, I don't think that as a physician, I have really put patients at the center of the care a lot. You know, we have this strong desire to practice evidence-based medicine. And when we are dealing with patients, well, our thinking is, what should I do for this patient? What is the best thing to do for this patient? Based on the evidence that is available today. And a lot of times, we don't incorporate patients into decision-making. You know, you just unilaterally make your decisions. This is what is best for you. This is how we are going to do management, and that's it. We don't even put forth all the options that are available as management modalities and incorporate the patient into decision-making. And at the end of the day, we are feeling that we have done our best, but we have not met the patient's needs. So I learned a lot from the course about putting the patient at the center of the care. Another aspect about patient-centeredness that I learned, which will really improve what we are doing, is that my hospital, for example, is a training institution. We work with residents. And a lot of teaching takes place by the bedside. I realize that a lot of times we see patients, we are with residents by the bedside, we discuss a lot amongst ourselves, do a lot of teaching, but then communicate very little with the patients. At the end of the day, the patient doesn't have enough information. What actually is my diagnosis? What management is going to be offered? And even the cost implications. When all this information is not passed across appropriately, at the end of the day, the patient is dissatisfied. And they go home with the notion that you have done very little. They haven't gotten the care that they hoped to get. So our eyes are open to the fact that we have to communicate more with the patients. We have to listen to them. We have to make them contribute to decisions as far as we are managing them. In our setting, we have had our own way of addressing errors in patient care. We usually advise staff to speak up when something goes wrong. But then when they speak up, our approach has not been very appropriate. Oftentimes, we will give somebody a query, oh, why did you do this like this? And a lot of times, people will face the disciplinary committee, and there are staff that have been sanctioned, different forms of sanctions, some have been suspended, some even dismissed. But then I came to realize that even the best trained doctors and nurses can make mistakes by virtue of the fact that we are human beings. And we need to change our approach to the way that we handle errors when they do happen in the course of taking care of patients. Because the more we handle it the way we have been doing, the more many things will go unnoticed. Because if someone knows that their colleague did this and was punished, and they fall into that trap, they will try as much as possible to hide it, and you might never uncover it. So the care will continue to deteriorate. And if we are not seeing where and what the problem is, we will not be able to find a solution to it, as one of our contributors said, that we cannot solve a problem that has not been identified. So our approach to things like error making in taking care of patients is taking a different drift at this point. The course was just so enriching. We were learning a lot. You know, you always think that you know a lot, but when you start learning, you begin to realize how much you don't know. We always had targets, like in a week we want to do this number of courses, but at the end of the day, more and more people were doing more than what they anticipated to do in the designated time frame, because there was just so much to learn, and that stirred up the eagerness for us to learn even more and more and improve on the care that we are offering our patients. We cannot thank Acquire enough. We cannot thank IHI Open School enough. I think that this quality improvement course is a must-do for every healthcare professional, and even the paramedics. Everyone has to be brought into the picture. Thank you.
Thank you very much for reminding us that the conversation and the care must be centered on the patient. Even as we communicate, as we engage in the technical conversations, the patient must also be captured in that conversation and be appreciated, because then patient-centeredness becomes critical. Yeah. You also highlight the value of the signals that we send through our actions. If we have a positive culture in terms of error discussions and conversations, then we will incentivize people to be open to talk about them. But if we don't, then first of all, we are human. If it's a punitive environment, then I will hide on the errors and I will not be open about it. So thank you very much for highlighting that experience from your facility in Cameroon. Dr. Edna, how has this been for you as a student of the course and as a practitioner and a mentor?
Thank you for this opportunity. And I think I want to just first begin by thanking the Acquire team and the IHI Open School. So I think earlier one of the speakers here on stage said, how do you know that the service that you're giving is a good service? I think it was Dr. Sepile, I think from South Africa. And it was a question around, would I consume the service that I am giving? And this is especially for us in public hospitals. And she gave a mention about your moonlighting. You're working here and working in the other place. And you're two very different people. So I'll just read a small quote that we received as the board for the hospital on which I work from a patient who came in. This was on social media. So what she said was, Mbagathi Hospital Pediatrics Department, well done. Surely there are good doctors and clinicians and nurses and lab technicians in public hospitals. I landed in Mbagathi Hospital with a sick child today, and the courtesy and professionalism I received from the gate, the cashier, the nurse, the clinician, to the lab tech was very amazing. May God take you all to bigger places. I'm grateful. May God preserve this for our people. So I think for me, I'm attached to the newborn unit. So I'm faculty, but I teach medical students in the newborn unit, undergraduates and residents. And I think what I can say based on a comment like that is, I think I would have my newborn baby taken care of where I work. So I think the biggest challenge for us is, would we consume the service where we work? So onto the journey of Acquire. It's been a very transformational journey for us. And someone talked about staff being short-staffed and not having opportunities. One challenge we have in our facilities, because we have few staff, going for training is always a challenge, and not many people get that opportunity just because of the constraints that there are. So, of course, when I told them about this course and told them the structure in which it's done, and that it's online, you can do it at your convenience. And it was an open thing, whoever wanted to do it, so it was voluntary. So I think the first thing that motivated our staff was that they could do something alongside the work they are doing. But when they started to do the course, what we did, we had a WhatsApp group where we would check in and talk. They kept feeling that this course is so timely because in the everyday things that we are doing, it was giving opportunity to apply this immediately. And just like my colleague here said, thinking about harm reduction and reducing errors, many of them felt that they wanted, because it was hospital management, are now working towards creating an environment or fostering an environment where people are able to speak up about mistakes or if something goes wrong. But also as a board of management, we also realized that when people are tired, then probably they would make these errors that they make, not because they intend to make an error. And so trying to think around facilitating extra staff in places where they are very constrained for staff, so that either work shifts are shortened, or if not work shifts are shortened, then they don't have to work as many shifts, they can have time off. And then the other thing, our hospital is also a teaching hospital. So we have that whole spectrum from diploma level trainees, we have undergraduate medical students and interns. And so sometimes there's a hierarchy where you find on a ward round, maybe the person at the top is doing most of the talking and asking questions, so they're kind of top down. But what I have seen, or personally what we are doing in the newborn unit, is facilitating an environment where the junior staff are able to speak up if there's a question or if there's management that they have some thoughts about, or maybe something that could be done differently, or even maybe where they see that something that has been done could have been an error, that it's safe for them to be able to then raise these things. So just fostering that environment where people feel safe to speak about things that they feel differently about, and ultimately the patient-centered care, because sometimes the mothers come and their babies are in the newborn unit for a long time. So on the ward round, you do a lot of things, you talk, and sometimes you talk past the mothers. So just at the bedside, being that practical example where you stop and talk to the mom when she's there, ask her some questions, and give her feedback and ask her what her thoughts are. That's been our challenge. Thank you.
Thank you very much, Edna, for highlighting this and reposing the challenge on whether we as the practitioners are comfortable enough to consume the very services that we offer in our very environment. You also emphasize something, a thread that has come across: the environment, the culture. Is it a culture that promotes openness towards patient safety, towards quality improvement? And that becomes a very important component. The other bit you highlight is how, through the training and through your practice, you've been able to point out drivers of patient safety and quality and inform management decision, whether it is a staffing issue, so that then it's not, you're not just dealing with the symptoms, you're also able to look beyond the symptoms to the root causes of some of the causes of medical errors, as it were. In the interest of time, because I know we have maybe 7 minutes, I want to open up this for any questions from the plenary and for the virtual team to these three champions of IHI and the Acquire quality course. Any questions? We will take maybe 1 or 2 from the plenary, and Ruth Paul will alert us when we have any on the virtual.
Thank you so much. Dr. Herbert is still my name. I thank the team, the panelists. My question and submission goes to Dr. Nya from Cameroon in terms of the communication strategies that you put forward, speaking to your patients. I wanted to know your experience about the customer or patient experience or surveys. Have you done any, and what is your experience? I have also been a scholar of IH of the second cohort, and one of the things that I realized was that we're not taking very keen interest in what do the patients themselves feel about themselves. And still related to that, the issue of explaining to these clients about the medicines we are giving them and the possible adverse reaction they are supposed they are to get. And like when they complain, they are not sure they get maybe a diarrhea or a vomiting or something. They are not sure whether it is a normal outcome or something, and what should they do. From your experience, have you encountered such, and how have you overcome this? Thank you.
We'll take maybe two more, and then we will come back.
Thank you very much for an opportunity, and thank you for sharing your experiences after you have received this training. My name is Mugisha. I'm a medical doctor and general surgeon from Tanzania. I work at a central zonal referral hospital called Benjamin William Mkapa Hospital. My concern, my submission goes to whoever feels like he's responsible or she's responsible from the panel. And it is about incidency reporting. We are coming from societies whereby corporal punishment have been shaping us from way go downwards. And that has affected so much to disclose when you have an incident. And it has prevented so many health workers to report that we had harmed you, or we have 1, 2, 3, 4. Now, after you have received training as this, how did you go to change the practice? What were the tools you used to improve incident reporting and avoid, because once you report is the day that you are told to stop working from today until we prove you wrong, we prove you right. That's number one. Number two, I would like to submit that quality improvement is the new terminology in our healthcare practices nowadays. We have been preoccupied by increasing access to care. A lot of programs within the government and non-government players into the health sector have been to really take healthcare very close to the citizen who are the consumers. And we have noted from curriculum point of view that quality metrics in healthcare have not been included in curriculum. Do you think a review of curriculum and having all stakeholders in the educational sector need to understand what we are really talking here, so that we can train doctors, nurses, and healthcare providers in our institutions with the skills that will necessitate follow-up, starting follow-up and improving quality of care. Thank you very much for the opportunity.
Thank you very much for this forum. I'm Simon Bugwa from Kijabi Hospital, Kenya.
Kindly project your voice a bit.
I'm Simon Bugwa. I wanted to ask a question on culture. Africa, every one of us come from a culture. And every patient who we meet come from a culture. There is a way a certain culture perceives healthcare. When a patient comes in, your outpatient perceive healthcare different than the other person. So they have the expectations. How do we make sure that we meet their expectation according to how they perceive it? Or does that again drives us as imposing our culture? Sometimes I would say our learned culture, because we have gone through school. And probably this could not be their expectation. They want you to go to what they are familiar with. Start from there. How would they get embraced in our different cultures, where we come from, like from our own perspective, because they have their own perspective. That's something that I really wanted panel to expound on.
Good morning. Oh, actually afternoon. I'm speaking on behalf of Odwor Otieno, who is with us online. Dr. Mulongo is asking to the three discussants, how has the improvement infrastructure improved over time when they've been running QI initiatives, especially with regards to redefining clinical governance with the lens of the quality of care index measurement? So I think it's about what is the internal improvement in infrastructure and how are we able to see that the QA initiatives are helping redefine clinical governance from the point of view of quality of care.
Okay, I think there was one last person, so let's just pick one and then, because of time, I know some of these questions will also spill over into the next session.
Thank you very much. Thank you, panelists. That was amazing. I just want to ask, I'm not sure if any of you had moved from theory to practicals, but I'm interested in understanding how did you get what did you find useful when you moved to, with the theory you've learned in the online course, to the practical phase of the course, and what lessons can you share in this room that will benefit leaders who are still going to lead teams to the practical phase? Thank you.
Okay, thank you very much. I think in the interest of time, let me try and assign these questions. So there's a question on patient experiences, and that was specific to Dr. Nora. There's a question on culture versus expectation. There's a question on incident reports and how we have been socialized still fits with our culture. So I think that I will hand over to Chris. And then there's a question on is there a need to even embed the quality or strengthen the quality conversation within our curriculum? In clinical governance, we are going with the quality conversation with the next set of panelists. So I want to defer that question to the next set of panelists. Aisha, that comes to your docket. Then I think theory to practical, I think largely what we've been sharing to a great extent has been trying to show us what the theory was, and to an extent the little bit you have done in terms of practical. But let's start with the responses with
Thank you very much, moderator. So at our facility, we have suggestion boxes at most entry points. And from time to time, we visit the suggestion boxes to see what is there. And we always encourage that when someone is dropping a suggestion, they include their phone number or their email address. Yeah, because it's not important for us to only look at this suggestion. It's important for the person who dropped the suggestion to know that we've taken a look at it. Because sometimes people might feel like, well, they just dumped this thing into a trash. Maybe someone is doing something about it or not. So when we visit, we look at what is there, and we get to the people who dropped those suggestions to acknowledge receipt of their suggestions and to ensure them that we have taken it to heart and are working on it. So those are some of the things we are trying to do, and we try our best to address what we can to the best of our capability. Secondly, when we are managing patients, we try as much as possible to let them know the common potential adverse effects of each management modality. Sincerely, we can't let patients know about all the potential adverse effects, but at least we try to make them know the most common. Because some of the conflicts that happen between patients and physicians arise from the fact that a lot of times they are in the dark about certain things. You could be managing a patient, they are developing an adverse event from the drug, but then simply because they were not informed, they will feel that they are developing a new medical condition, or your drug is making them worse. And that leads to poor quality. So we have realized that when you educate the patient about those potential adverse effects, and it's happening, it's already at the back of their mind that, oh, the doctor talked about this. I shouldn't be discouraged. Because sometimes they unilaterally stop the treatment when those adverse effects are happening, simply because you didn't talk to them. So we've realized that it helps a lot. Yeah, they know when to come back to you. They know when to continue taking the treatments, what is severe, what is mild, and might potentially go away. So that education is key, and it's been helping. Thank you.
Thank you very much. Let's go to the culture conversation.
Thank you so much. On culture aspects, long time ago, before we started the quality improvement projects, we had issues where the patients, even the staff ourselves, we felt like our culture is not right. I've done something wrong, I can't report it, because if I reported it, the next day I'll be home. So what we did is we went through a culture change process that involved everybody in the facility. We first of all identified what culture do we want, which is the positive culture that we want to incorporate in giving out our services. So we listened to our clients, we collected feedback, as my colleague has indicated, and wanted to know the pulse of the patient, because the patient is king. So when we identified what we need to change in our culture, we brought our teams together and we took them through a vigorous culture change process that ran over 2 years. Every staff was told, why is it good to treat a client in a given manner? Why is it good to look at our processes and not look at individuals? And people started becoming open in reporting matters, in reporting errors, in reporting achievements. We celebrated the achievements and we looked at the errors that we made from the audits and from the feedback. And that's how we looked beyond the culture of audit and beyond the culture of feedback. Currently, what are we doing? That culture goes on. That is not about the audit, is what can we do to improve our processes. It's not punitive. It's only punitive when it means that it was very intentional. Because if I've done a procedure for more than 1,000 times and I've missed one time, what made me to miss this one time? I should not be punished for that, but the system should be corrected. A positive culture is what we run on. Thank you.
Thank you, Chris, for that response. Curriculum, quality, training.
So thank you to the one who posed the question about curriculum and introducing quality improvement. Certainly, this is an important thing that we should think about. But wearing my academic hat, curriculum review is a very major thing in academia. The speakers from the previous panel talked about there's doing our work as medical practitioners and improving our work. So when we think about it that way, when the medical students or the interns or the nursing students are with us when we are doing the work we are doing every day, how are they encountering the steps we are taking to improve this work? So I think there's a two-pronged approach where at the bedside, having gone through this training, and I've already seen some of our managers in the hospital already applying some of these things, then immediately it translates to beyond I come to work every day and do what I need to do and get my paycheck. There's now deliberate strategies that different departments are putting in to improve their work. And my colleague has mentioned one of them. For us, we have an open policy where people who come into the facility can report directly to people who are on the hospital board, or they can be able to use our social media platform and put their comments there. And usually we prefer that they put a contact which we can reach them on. That's an example of one of the comments that I read. We received it on our platform. So in terms of actualizing this, I think it is to begin immediately, start small where we are, but definitely I feel curriculum review and including this as part of basic training, because again, we can't teach old dogs new tricks. If you didn't go through this sort of orientation, if your mind is not wired this way from the word go, then it takes a lot more to wire that mind differently. So that's how I view it. Thank you.
Thank you very much. A round of applause for this first set of panelists. And thank you for reminding us that quality in itself is about culture. Quality is a journey, and the patient should be at the center. So thank you very much, and I'll allow you to take your seats as I welcome the next set of panelists. A round of applause for them. Oh, the photo. The bedside to the boardroom. And to help us have that conversation, we'll have Mr. Bernard Omondi. He's a quality improvement manager at the Metropolitan Hospital. He is a seasoned expert in business process improvement with over 20 years experience in quality. And on a side, I was telling him that their hospital has done quite a lot, silently though, in terms of strengthening the integration between quality and digital health, yeah? And some other day, we'll have a conversation around the role of technology in leveraging quality. We also have Dr. Neema Ali Mohammed. She's a medical doctor and a specialist in public health system strengthening. She heads quality and health standards in Mombasa County since 2017. She's a trainers on quality, KQMH, and a strong believer in systems approach to quality improvement. And we are happy that even as a Society of Quality Healthcare in Kenya, we were able to learn from their experience in Coast as far as quality improvement is concerned. Welcome, Daktari. Did I mention that Bernard is a certified ERP trainer and auditor for the Kenya Bureau of Standards? I have mentioned now. So we have people, strong people on the panel. So this too will help us unpack the quality journey and the integration at the institutional level, facility level. I also want to welcome to the panel the team that will also help us unpack this conversation in the policy space at county level. In Kenya, our healthcare system is devolved. You have policy largely at the national level, and you have service provision largely at the county level. It would be nice to hear the experiences at both levels as far as policy decision making is concerned and the integration of quality. So to that extent, we have Mrs. Violet Makoha. She's a continuous quality improvement regional director at the Center for International Health, Education, and Biosecurity. We appreciate that she has made the sacrifice to be here because she traveled in the morning. She has 15 years of experience, she has 17 years of experience, 13 at CHEB. She has previously been a director of quality improvement at CHEB Global, and the accolades are significant. but we are proud to have you join us. And again, as a society, we were happy that we were able to learn from her experiences also with in our monthly quality webinars. And finally, we have Dr. Aisha Mohammed, public health specialist, graduated from the London School of Hygiene and Tropical Medicine, holds an MBA from the University of Leicester. Currently working in the Directorate of Standards, Quality Assurance and Regulations in the Ministry of Health, with a focus, with a special focus on, let me just read this, quality improvement in healthcare. Now we have a team that spans, again, in the economic space, we talk about the micro level, which is at the facility level, and also now looking at the meso, which is at the county level, and the macro at the national level. It would be nice to now hear from them what their experiences have been. We'll start with Bernard. What has worked for you in terms of integrating healthcare across all the systems within Metropolitan Hospital? Not just at the bedside, but also in the boardroom.
Good afternoon. My sincere appreciation to the team at Acquire for giving us this opportunity. In the side conversation, one of the things I appreciated was shared learning. This is an opportunity for all of us to put our heads together, see what is working for us, and if others can emulate that and see if it can add value to their processes as well. I'll start by saying that one of the things that works from the word go is top management support. If the top management buys into the idea of the value add of QI in all our processes, the journey begins and the successes can be realized a lot sooner. Because somebody once said, quality is not expensive, it's priceless. That effort that you put, and you remember that at the tail end of every effort is the patient, it gives you the sense of satisfaction that the desired outcome of patient care is what you are achieving because you are invested in it. One of the areas that we started with was a change in mindset. And I know we've had this discussion before, but let's look at it from a different perspective. People would look at quality, especially if there's an established department called quality assurance. Then you say, this is my work and this is quality. That's a compartmentalized thinking. But what we need to learn from that is if we remove it and say that quality is an integral part of what I do every day, then we begin to realize those successes. And I'll give an example that worked well for us. Most hospitals have forms or data collection tools that you have to complete different fields in that. So in that form, you have fields, and then you decide to leave some of them blank. So we started by training our staff to be aware. If that field wasn't necessary, then it shouldn't have been in that form to begin with. So when you have a form and all those fields need to have some information in it, why is that information key? Why is it important? I'll give a good example, very simple. You're taking care of children. You're in a hospital, and part of the information you have to put in that form is age, date of birth, sometimes they mean the same thing, weight, vital signs, and you add all of them. And you keep finding that some of them have been left blank. So you ask a very simple question. Why is it important for a nurse to put the weight of the patient in that form? If the nurse realizes that at the tail end, at the end of the process, the doctor or the pharmacist is going to give a dosage based on the weight of that child, then you realize, why is it important for me to put that information there? It might look simple, but it has very important implications. Number two, exploiting the tech environment. And one of the challenges we've had is somebody missing out a piece of information. For example, you ask a patient, do you have any known allergy to medication? So you use the technology that has been provided, and some of it we adjust it as we move along. So last time, the last one we created was, if you enter information about allergies of a patient, the system in the back end is set in such a manner that the doctor who's going to make a prescription will not necessarily have to remember what were the allergies that the patient has. But the system is configured that in an attempt to prescribe that same medicine with the formulary that can cause that allergy has already been disabled. So you're using technology as much as you can to assist the doctors or the healthcare workers prescribe, deliver, and give care that assists, that yields the desired outcome you would like to see. Thirdly, individual and collective responsibility. Every person knows that a process has a beginning and an end. What we train our staff, what we tell our staff, please realize that what is your output is somebody else's input. What are you giving the next person? Is it of good quality? Is it something that person is going to use to deliver a desired outcome? Once you know you're part of a chain that at the end of the day is responsible for making somebody else's work better, then you go ahead and you deliver it. Be aware all the time your output is the next person's input. I like the conversation we're having about reporting, incident reporting. And I want to give you an example of how we've been able to use different tools that aid in the fact that we don't want to penalize people for reporting incidents. I'm sure most of you are aware about a tool called Fishbone. It has 5 different M's. And one of those M's is the manpower. Man. In our work, we try to make sure that we look at that one the last. Is the method working? Is the material working? Is the external circumstances working? When we have exhausted all the other areas, then now we can look at the man, the skill. And then when you look at skill, begin with, is the skill mix right? Is the skill given to that person to perform that task adequate? So that any time an issue occurs, form a multidisciplinary committee, investigate it, then arrive at the correct solution, always remembering that blaming or assigning blame, apportioning blame will not yield you desired results. And when you use that tool and you look at man, the last, you encourage people, you create a culture where somebody is confident enough to report that an incident occurred. And then you flip it over and also say, when you fail to report and we find out about it later, then now it becomes punitive. So it gives somebody the courage and the confidence that it is okay for me to report, because then I get an opportunity either to learn, change the process, re-engineer the way we work, or improve the skill that has been given. Last but not least, we've mentioned curriculum, and part of something that I wanted to share is KEBS and CASNEB came together, and part of what they're doing is developing a curriculum in quality management. When that is rolled out, different institutions are going to be licensed in Kenya to offer that course. But then the most important one is our own curriculum for training nurses, doctors, healthcare workers, such as patient attendants. We integrate quality as part of their daily learning. Thank you very much.
Thank you. Thank you very much. Daktari, over to you. How is it at the coast? And what's your experience? What is working for you?
Thank you, Dr. Mike. Good afternoon. Allow me first to express my excitement to be in this leadership forum amongst distinguished leaders in quality improvement. I'm as excited as a child is when they enter like a toy store and they're not sure what they want to take or how they're feeling. And I feel like these discussions are so healthy, and I want this to be happening even, longer and more often. And so I skip straight to what is happening in Mombasa and what has been working. And I want to begin by saying that quality that doesn't just happen by chance. It doesn't happen by accident. It's from efforts, smart efforts from people, from the teams on the ground, through the systems. And to begin with, I'm a very heavy believer of the health systems approach. And we advocate so much in Mombasa from top leadership for quality to be embraced at all blocks of the health system, from the governance to human resource, from financing, and all aspects up to service delivery. And we say that it is not just one person's business, but everybody's business. Everyone should know their role in improving quality, right from the guard at the gate to the accountant to the person meeting the clients at the service delivery points. So that has worked well for us. And when we collaborate with different partners that come to support quality improvement, we take the same approach. And we say that let's not look at quality in terms of what you're just offering for a certain part of the system, but let's look at it as a wide approach so that everyone gets to benefit from these kinds of collaborations. For us, we started quality in 2017 where the unit was established. But since then, we have managed to achieve some milestones through the formation of quality management structures whereby they are assigned people to oversee quality improvement and management, right at the county level, down to the sub-county administrative level, and up to the facility, and even in some of the community units that we have managed to capacity build, we have those focal people who oversee quality and encourage the quality improvement agenda. And that has really gone a long way in terms of advocating for quality improvement. As you all know, quality is taken with resistance, quality improvement, and it hasn't been an easy journey. With all the health system challenges, someone feels like you're just adding them a burden. You're telling them, let's offer this service better, but with the right attitude and the right encouragement. And when people start to see the fruits of their first initiative and their second, and they start to just have that self-belief, and they start to just propel, also be advocates of the same agenda. As part of institutionalization of quality management, we have, as Mombasa County, developed a quality management policy in 2022, and in this policy it has provided much guidance for us in terms of quality management, our governance structures, our standardized processes in terms of quality improvement processes, and some of our tools, and therefore this has really helped to drive the agenda. So through these strategic objectives within our policy, our teams are able to take up thematic quality improvement projects to improve on parameters based on the different strategic objectives. For example, in terms of patient safety and things like that, employee satisfaction, in terms of patient-centeredness. So I have a and I feel like this is our most influential strategy, building a pool of coaches. Building a pool of coaches who understand quality improvement, who are passionate, who are able to mentor and coach fellow colleagues across the health system. So this has been an approach which we have embarked on for the past year, and we are really seeing fruits on this. And we are saying that you don't have to have gone through the whole module of training, but gradual mentorship until you fully understand quality improvement makes you a coach. And therefore what we do is we map out these coaches whom we feel are already knowledgeable enough to now spread this knowledge to teams, work improvement teams from different facilities, and within even the different facilities to different departments. And that is how we try to spread this knowledge. Additionally, in terms of knowledge sharing, we try to do CMEs, online webinars on a weekly basis, quality improvement webinars, whereby we allow our own coaches, our own team members to present on different quality improvement processes to build the capacity of other members. And this has really encouraged our teams, and you find people coming up and saying, even I want to present on this topic, and I feel like I understand it. And we let our people, just grow in this manner. And it has really gone a long way. We have found those who are not advocates now are advocates of quality, and they are coaching and they are propelling this agenda, and we are seeing much improvement initiatives across. So we also encourage a lot of recognitions and rewardings, not very high end, but even at local levels, facility level, just having the employee of the month picture and saying that we recognize you for your efforts. And we do hold learning sessions, quarterly reviews, whereby we acknowledge the quality champions, and we try to award as many certificates as possible just to make people feel that positive energies, to get the positive energies. So, and we also try every year to apply for the National Quality Awards. And I have to say, our teams really look forward to this time, and you can feel the laughter and the happiness when we are doing our drills and we are going through our projects, and people are so hyped and they're like, wow, yours is so nice, oh my God. They start to re-strategize. And I think that passion is just what we are looking for. So something that we have been trying is to use digitization in some of the processes in our capacity where we are able to. And some of the things we're doing is reporting our coaching sessions through a Google form. So we share this link with all our coaches, and we have a WhatsApp group that has all the coaches, and we keep expanding into this group. And this link is where when, for example, I do go for a coaching session, it's a very short tool. You just say where you went to, the date picks up automatically, what area were you able to coach on or mentor on, and what are your action points from there to follow up on the next coaching session. And so this is just a Google form we just created, and it's been working, and our coaches are clocking in, not as much as we want to. Sometimes you ask, how come we are so low? And people say, oh my God, I did 5 sessions, I didn't clock in, but it's still a work in progress. And we really like to embrace these digitalized systems. We also do customer satisfaction survey through the Kobo tool, Kobo platform. We have an account, and also in collaboration with some of our partners. That is the same way we do the employee satisfaction surveys. So I was telling Dr. Mike, 7 minutes is not enough to talk about what has worked. But again, I wanted us to, and I was very afraid to speak after Dr. Bernard. I thought maybe he'll say everything before me, and I'll be left without anything to say. But again, I just wanted to give this takeaway that leadership is key for quality to succeed. And that is a lesson that I have learned across the years, that if the leadership does not back you up, it does not commit, then it will fail. Quality will fail. There will be no morale, no improvement, no nothing. So that advocacy has to really happen right from the beginning at the leadership level, so that this vision of the leader can project downwards. Finally, I've had a lot of talks on error reporting, incidents reporting, and I love it, and I love that we are starting this conversation. And perhaps I wanted just to ask ourselves here as leaders in quality, what can we do? We know that incidents reporting is an issue, and perhaps in some areas it's working, people are reporting these incidences, but how much are we reporting really? How many reports do we have? Can we quantify them? Are they the reality versus what is happening on the ground? And there's so many factors that are preventing us from reporting these incidences. One of which I feel is the heart of it is the psychological safety. We don't feel secure enough to report. There is the assurance you can be given by your leadership that just report, nothing will happen. But what kind of assurance is that? Is it a guarantee? And that is where most of our healthcare providers, they are in that dilemma. And I want to just tell a short story. A few years ago, maybe not so few, I worked in the clinical sector in a small hospital. And there was this child in the pediatric ward that we were treating for severe dehydration. And by the second day, this child was just running around, walking, and I was telling him, I'm going to discharge you today. And I was called back to the outpatient department to see some clients before going back to finish my ward round. And as I was seated seeing a client in the outpatient, I got a call from pediatric ward. We have an emergency. Tell me, what is it? And to my shock, this child who was running around is now gasping for air. In the morning, I just met him running around. He's gasping for air. Why? So I went, and unfortunately, we were not able to save him. He was already in his death status. Looking back now, what happened? And people are afraid to talk. Everyone is just mute. And someone on the side told me, unfortunately, he got potassium chloride directly intravenously, not through an infusion at a slow rate, the way it's supposed to. But for those who don't know potassium chloride, it is the lethal injection. It is what is used to deliver the death sentence. So this child got potassium chloride directly intravenously. Ideally, it should go as an infusion, slowly, over hours. So I didn't report these incidents. The nurse in charge didn't report these incidents. The parents came and picked their child's body, The father left in the morning when handing over to the mother that, okay, we are going home today. And they come to pick a body. So what are these factors that are making us not to report? We saw it, we heard it. The nurse who mistakenly did this had just come from a night duty at another hospital. And he came into a morning duty in this hospital. Not blaming him, blaming the system. But what prevented us from recording this as an incident and learning from it? It just went under the water and people went quiet. So today, I want to advocate. I want to advocate for one thing, if it is an output that we can come out of from this meeting. is that we need to come up with a protection mechanism, a legal framework for incidents reporting that is going to assure all our healthcare workers that if you did not, nobody comes, Dr. Tenza said, nobody comes from home coming deliberately to kill someone. It is a lot of factors that lead to that. But I recognize as a healthcare worker, and I would maybe want to report that I almost, or I did, but I'm afraid. So we need to come up. We are leaders here in quality improvement, and it starts with us. This agenda can be sparked from this meeting, and I request that we come together to change the narrative. Let's come next year and say, this is our incidence reporting rate. It came from this level, and it's now at this level. And we are learning. And this we are seeing even at the moment as we do our maternal perinatal death surveillance reviews. Yeah? Even the stories that are on that report, they're not real. People are still covering their tracks. Why? We are afraid. So let us come up with a way to protect our healthcare workers, to make them feel safe, just to report, to say that, okay, I made a mistake, and I didn't mean to. Of course, they didn't mean to, but they are protected. So just on the table, let's think about that. And yeah, thank you. I'm really privileged to be here. I'm excited. I want to hear everything. I put my laptop there at the back under my chair. I didn't want any disturbance, and I'm really learning a lot. Thank you.
Thank you very much. So, Violet, we've had what is happening in Mombasa County, and it has been humanized by the experience she has shared as well. I'm curious now, what, from your experience, even as a partner supporting the counties on quality improvement, what seems to be working?
Thank you so much. Good afternoon. Yeah, I'm largely glad to be in this forum today, just to discuss quality matters as leaders, and it is a great opportunity for us all. Just to begin, one person who have come to believe that, to believe in change, as much as not all changes lead to improvement, but I always believe it is good to try a change. And I'm glad that today we have tried that change, and it seems to be working, looking at the virtual attendance and all that. Most of the time you'll be seeing us talking, projecting, and this is, I think, a good change, that we are not looking at slides. So just to begin, and picking from what we've had from Mombasa County, quality without leadership is no quality. It is a pillar for achieving quality in healthcare system. This is because from the experience I've worked with several counties as an implementing partner, and to start with the first experience when I was a quality improvement officer within Nairobi County, which was then a city county. We had the government rolling out the Kenya Quality Model for Health, and people were trained, as we had earlier, Dr. Asha mentioning that we had 3 coaches from every county trained on quality improvement to disseminate that to the lower levels. But then at the national level, after developing the policy and training the coaches, the 3 coaches for the counties, so what? So it doesn't end there. So for us to be able to realize implementation of what is in that policy document, then there has to be structures that support that particular implementation. And so if you don't involve leadership, even if you start, implement, and get to the end, it is like you haven't started. So you have to sit on a table and be able to strategize and be able to lay out a plan of how that is going to happen. So I'll give this experience, both the positive and lessons learned. So one lesson we learned as a partner implementing in Nairobi County, because the guideline had been rolled out, so we went ahead as a partner, trained the facilities that we were supporting, the sub-counties and the counties that we are working with, and thought that that is it because we have trained our people, so we will be able to implement the policy. But then later on, after about 2 years, we realized that within the county, it is only, by then we were University of Maryland. If you want to hear about quality improvement, you will only hear from University of Maryland, yet we are a county. So that we learned a lesson, and we had to go back on the table and sit with the county leadership and start to strategize. So the first thing we started is coming up with the county leadership, an infrastructure that would guide that implementation, and that was forming a county TWG, Technical Working Group for Quality Improvement, that was now supposed to work on a plan that was jointly done with the partners so that we can be able to implement downwards. And from that, we were able to form an infrastructure for quality improvement for the county, including structures that were implemented in Mombasa County at sub-county and facility level. Then we asked ourselves who is supposed to be trained. You know, with quality improvement, not everybody, as we have mentioned, will take quality and move with it positively. So we had to identify who are these we can train as coaches that can be able now to implement, to support in terms of implementation and also at facility level. So with that joint plan, we were able to jointly train, now not just training staff from the partner supported facility, but doing this as a county. And we did that jointly, and now we were able to have a number who are trained, because there are challenges with staff turnover, with funding issues with partners. So if we were able to train a pool of quality improvement focal persons and also coaches drawn from across the whole county, that helped us to be able to cascade that down. Then, of course, with the formation of the county TWG, there were clear roles and responsibilities in terms of reference that the county level team would work with to ensure that that particular implementation has been done. Talking about that, again, so moving forward as a county, they were able to form very strong quality improvement teams at the sub-county and the county level and the facility level. And then with the work plan that had been developed jointly, then it meant it was an up-bottom approach, but then quality works two-way. It can be up-bottom or bottom-up. So from that establishment of a clear infrastructure, implementation had to start with the bottom, from the facility level, so that now the facilities are able to use data. And as we had mentioned earlier from the earlier speakers, there is no quality without data. So using data, looking at what they are doing and the performance, they could be able to identify areas that they needed to improve. And then now that is cascaded upwards to having best practice sharing forums, to having learning sessions, and even having quality collaboratives, so that now we can be able to talk about institutionalizing quality improvement at the county level. And that now led to development of quality improvement best practice forums that are done at the county level. This has been now rolled out in many counties within the country, and it is happening as something that has been institutionalized. Nairobi County, being one of those that had done this earlier, has now come to develop quality healthcare awards, and they are now able to, they are now doing the 5th one, I think, in terms of just awarding facilities, teams that have been able to implement quality improvement at that particular level. So, other than leadership, there are also challenges that come along with the implementation of quality at the policy level. Yes, we have built capacity of service providers, we have built capacity of the leaders, but then come this challenge of you train so-and-so in Mombasa County, and now today, Dr. Asha has been moved from Mombasa County to Kakamega. How will we be able to sustain what she has started in Mombasa County, and how will she be able to pick up Kakamega County and continue to sustain that quality implementation? So one of the things that is also very critical in terms of establishing a quality system in healthcare is integration. And what has worked so well in terms of integration, as a program also, having funded to implement HIV care and delivery, we realized that by focusing only on vertical implementation, it will not work. So what happened? We developed work plans with the counties in terms of looking at quality in totality. So when we do support supervision at the facility level, it is an integrated support supervision where it is looking at everything from maternal health, from HIV service delivery, TB, HIV care, radiology, and all those other departments, so that integration becomes very critical in terms of ensuring institutionalization as well as sustainability of what we have already put in place. And also, in relation to that, as a program, we also developed a mechanism where when we have new staff on board, in the orientation package, we would have a session of quality improvement so that we build that organizational culture of quality improvement. And that has been established in that, even to date, anybody who comes as a new staff in the program knows that our foundation is built on quality improvement, because we have a whole session that the new staff will be taken through quality improvement orientation for us to be able to develop and sustain that culture of quality improvement. And that said, we were able to develop, and Dr. has mentioned that as well, in terms of digitizing as a mechanism, as a capability for sustaining quality improvement. A lot of things happen out there. A lot of quality improvement initiatives are done out there. Facilities come up with very good innovations, they implement, they achieve improvement, but then down the line, you realize that 2 years later, they have gone back to where they were initially. So what happened? If, for example, awards were done in 2022, and a facility in Mombasa County was awarded as the best performing facility in terms of reducing maternal mortality, because they did 1, 2, 3. Then how come 3 years later, this facility is again listed among the worst performing facilities in terms of maternal mortality? So that means the initiatives that were there before were not sustained. So what did we do? We came up with a digital platform where once these best practices have been shared, they can be able to upload and they can be able to track any quality initiative, so that at the end, anybody can be able to log in at any particular time and see what is it that was done here. We can be able to borrow. It is now a learning session. It's now a learning platform. It's a resource platform where somebody can be able to log in and see what is it that worked in Naivasha when they did PMTCT integration that I can be able to borrow from. And so currently, because we worked with the county and also we worked with the national team, we sat in the same forum, we were able to come up with the workflow for the digital platform. And so because it has that ownership, it has been scaled up to 35 counties now as we are speaking that are utilizing that particular platform. And so anybody in Mandera can be able to see what is happening in Nairobi County. Anybody in Vihiga can be able to see what is happening in Makueni in terms of maybe retention, in terms of appointment keeping, and any other. And we have diversified the platform in that we left the vertical approach to the horizontal approach. So the platform now integrates every health service delivery department, aligned to the Ministry of Health policy document. And that has really helped in terms of learning through the platform, and it is now helping us to come up and develop a community of practice for quality improvement that will really be able to inform, to allow us to learn, to allow us not to reinvent the wheel, to sustain innovations that have been implemented and have worked. So that is also another thing that has worked in terms of working with the counties and the experiences that we have had with the several counties within the country that we have worked with. As I end, there are challenges in terms of financing and HRH. So we are talking about structures for quality improvement. We are talking about institutionalizing quality improvement, and it can't happen minus the structures. So when you talk about HRH, what do you need to put in place in terms of having a sustained support for quality improvement from HRH, because we are looking at this as a system. And one of the things is capacity building, which does not end there. Once you have capacity build, there has to be a follow-up of what is the impact of this capacity building. And one of the things that we are working with, and Dr. Aisha will be able to talk, I think, more about that, in the framework that we are currently reviewing, is just to ensure that the issue of curriculum that came up, there is a component that has been incorporated so that you can be able to capture how quality improvement can be integrated even in the in-service trainings, so that as people come up, as graduates come out to start implementation, they have the idea of what is expected in terms of quality improvement to achieve patient safety. And another thing that I think in the discussions that has come up that is related to policy is realizing that there are so many approaches in terms of quality improvement, the models for improvement that are being implemented, and with this, the framework, in the framework as a policy, as an organ that is related to policy development, we have come up with an equation matrix that looks at these different standards that are being implemented, and looking at our Kenya quality model of health standards, so that we can be able to come up with a framework that is able to incorporate all the approaches and all the standards as one in the framework, so that we don't leave anybody behind, because different standards will apply to different quality service delivery areas. And so I would wish to end there as we continue the discussion.
Thank you very much. I know we have, time is far much spent. Ruthpal.
I know that Dr. Aisha will speak from a national perspective, so maybe let me bring in the online people before she comes in.
Perfect.
Is that okay?
Yes.
So you know, as I keep saying, there are more who are out there than who are here. So I want to make sure they keep being heard. Eunice Bett says, great testimonials from the panelists. It's good to note from Dr. Bernard that KEBS is coming up with a training curriculum on quality. Is it possible that other healthcare regulators, for example, NCK, could be involved to ensure the nursing curriculum also has this quality element? There's another one saying, thank you for digital tool implementation. How far is this being implemented? How many health facilities are currently digitalized? I think that must be to you, Violet. Martha Owiti is a doctor who has been a part of our Acquire QI virtual training. And she says incident reporting is mandatory. It's a mandatory requirement for hospital accreditation. However, the performance of the reporting system is far from satisfactory. What is Dr. Nema Ali's input on this? The final one is from Odworo Tieno, and he says, wow, hats off, great conversation. Psychological safety remains our most urgent pressure point in enabling a warning system. How are we inputting psychological safety into what we are doing and how we are thinking? So there's a variety of comments around the systems, processes, support system, just to ensure that the online voice is also a part of the conversation.
And thank you very much, online participants. It's very reassuring. It's lunchtime, and you guys are still there, and you're having heavy comments and feedback. We really appreciate. That tells you that the conversation is quite titillating. So thank you very much. For the questions, we will respond to them after Dr. Aisha speaks, I'm sure she will speak to some of those. Yeah. So let's welcome Daktari to speak to this now from a national lens.
Okay. Thank you very much. Once again, colleagues, good afternoon, and I'm delighted to be here with you to discuss this very important agenda. And you can see there's a lot of passion in this side of the room, and I know that is actually even higher on this other side of the room and the online participants. So my submission will be quite macro because I'll be looking at the capabilities in terms of the national level. So what are the structures that have been put in place that are actually helping us achieve in strengthening the health system in all the pillars. So I would like to start with the fact that for us in this country, taking into cognizance of the fact that we have people that are outside the country, people that are not from Kenya. So for us in Kenya, the highest law of the land actually acknowledges quality of care. And our constitution, the Constitution of Kenya, actually says that it enshrines the right to, for every Kenyan to have the right to the highest attainable standards of health. So we are held accountable to that level of our constitution. So that is the first level that I had wanted to bring out. Then following that, I wanted to look at the legislative and regulatory structures that have been put in place that are strengthening the system. And this comes from an angle that we realize that some of these things, quality of care is, improvement is voluntary, but we have to have systems in place that propel that agenda. We cannot just leave it at, someone just deciding, I want to do this, I don't want to do this. So based on this, there are a few acts of parliament that have been put in place to assist the country all the way to the facilities to make sure that quality of care is continuously improved. One is the Primary Health Care Act, which ensures that the care that is provided at that level of the lower facilities, as close as possible to the citizen, is funded for and is of a certain defined standards. Then we have the Digital Health Act that now is now the pillar against which that we are moving towards digitizing the entire health sector. We also have the Facility Improvement Financing Act, which is a big deal for us because since the devolution of how our country is governed happened in 2013, we have been struggling with facilities having funding to actually continuously improve quality of care. And this now gives them the liberty and empowers them to actually use the fund that they collect to actually plow back within the facility and improve quality of care. We also have the Social Health Insurance Act, which now defines the package, and this is more towards the access to care. So quality of care in terms of how are we accessing care, so that the indigents and the underserved, who most probably would have the worst indicators, are actually catered for. And this as well is where, if you remember I mentioned earlier, this is where we are tagging the assessments for quality of care to be based on. So for you to be on board this social health insurance fund, then you would have to show your performance in terms of have you been assessed for the minimum safety standards for joint health inspection, and are you on board quality improvement, which is now the Kenya Quality Model for Health. So those are some of the regulatory and legislative structures we have put in place as a country to ensure that rollout is done properly. Something else that is in the pipeline, this one is not even a bill yet, but we are working on a quality of care bill to make sure that quality of care has teeth, to make sure that we have an authority that will now start following up and making sure facilities are complying to standards, continuously improving quality of care. So those are on that item. I would also want to speak to policy structures that have been put in place at the national level. So at the national level, we'll put in policies that now the counties will implement. So I will start at the Vision 2030, which is a blueprint development agenda that identifies health as a pillar, as one of the social pillars. So that is where we now derive everything else in terms of where do we want to get to as a country by 2030. And one of the biggest issues that we plug into when we're advocating for quality of care improvement is that the Vision 2030 wants us to be a medical tourism hub by 2030. You cannot do that without having proper structures for quality of care. So that is at least a policy document that is driving our agenda. We then have the Kenya Health Sector Strategic Plans. We have the Kenya Universal Health Coverage Policy. We have the Quality of Care and Safety Policy. So all these policies actually help us to articulate what are the things we want to do in terms of quality improvement. When we come to strategies and frameworks, I know Violet has mentioned here, but we also have the Quality of Care Certification Framework, which I alluded to earlier on, that lays out how do you do regulatory functions and mix it up with quality improvement functions. So in terms of policy structures, those are just a few that I wanted to highlight that we have in place. And then in terms of how do we make sure that we now at the facility level, people are complying and they have proper structures to perform their duties. So the country has developed norms and standards for that. So we have standards for human resources for health, we have standards for infrastructure, for leadership and governance, for health service delivery, and even community health. So that all the way to the community level, we actually defining what are the norms and what are the standards that we need to meet for us to improve quality of care. So that is in a nutshell some of the structures we have put in place. So based on this, some of the things that we are doing is that we have embraced digitization. We have developed these tools that I mentioned are actually in electronic form. So that way you have access to ease of doing business. You can do your assessments easily. You can measure how you did last quarter as compared to this quarter and how you can come out with your quality improvement tools. And then as a country, we also decided to work and link with international agendas and platforms. One is the quality of care for maternal and newborn health. And we have really used that as a roadmap towards how we do improve quality of care. So this is like a pathfinder for us. The MNH has really been a pathfinder for us in all the initiatives that we are doing in quality of care, and has really led to us building the systems as we are now bringing on board other departments. Lastly, I would want to mention what has been mentioned before about integration. So at the level of a national level, we have really tried to bring things, in one area. I would speak to the Kenya Quality Model for Health. For that one in particular, we have tried to bring all assessments to be brought on board within that same platform, because we've been having people doing, quality assessments using different tools and different, platforms. So we have brought on board different specializations. We have, for example, we brought on board ophthalmologists and told them, what are your standards that you want on board for quality improvement? How would you define standards? How would you define quality improvement or quality of care in this field? People working on oncology, people in the renal field. So all these have come on board and given us, standards that they would define, which we are now using to start defining centers of excellence for those particular strands in healthcare. So I think I would like to stop there and just say that there's a lot to be discussed, but I'm sure we will pick it up in the conversations. Thank you.
A round of applause. So thank you very much, dear panelists. I think I'll just welcome a few questions from the plenary. I know it's way past lunchtime. Maybe let's just agree on 4 questions from the plenary, and Ruth Pearl, in case there are any other questions. Yes, okay.
Thank you so much. I'm excited. At least I'm gaining a lot to take back to Nigeria. But I have a few questions. The first one is that it is good to know that Kenya has policy structure identifying it as social policies, and having other arts, primary healthcare arts, digital healthcare arts, facility improvements, financing, arts, and standard. So my question is this. So what are the practical approach in place to ensure compliance and implementation of the policies? And what assistance is the government putting in place for staff to have a soft landing in ensuring the delivery of quality service at our healthcare windows, as in the facilities? That's one. The second one is this, ma. How do you measure your progress or otherwise? Because whatsoever that is not measured cannot be improved on. So how do you measure that, okay, those strategies that you have put in place, those arts, those policies, are really achieving the objectives? Then the third question is about incidents reporting. Fantastic, Dr. Ali. In fact, I'm quite excited and pleased with your the story. Quite unfortunate that it ended that way, but at least we can always learn from our mistakes. So, aside from reporting, how do you ensure that there is no repeats in the future? What strategies are you putting in place? Because it will not be good enough for us to keep on reporting incidences, near misses, and at the end of the day, a repeat of such will happen. So if we are just reporting and we don't put strategies in place to avoid a reoccurrence of our near misses, we might not at the end of the day be able to render quality service. Thank you so much.
Okay. I'd like to appreciate the panelists and for sharing your experience. Kenya has been at QI longer than maybe I can say everybody here, and it's so heartwarming to see something that works. So thank you very much. Well, you ended with the incident reporting, and it also came up during the basic IHI panel, whatever, discourse. Incident reporting is just one leg of a table. That table is not going to stand with just that incident reporting leg. You need to have the other aspects in place before incident reporting will be a success. And where am I going to? I'm going to just culture. I'm going to leadership. You can't tell me, BC, if you make a mistake, please report it so that it will not happen again. And you expect me to report it when I'm not sure that my leaders will also have that framework and come from, this is important so that it does not happen again. So incident reporting will not be successful if leadership is not taken first and just culture put in the place where it should be. So before we go to the workers, you have to start from the leaders. Do the leaders know what just culture is? Do they know that they have to understand that to err is human? And to understand that the mistake I've made is not because I want to, it's not my fault, it's the system that is not structured to prevent that mistake that I have made, and not to blame me like everybody has been saying. So all in all, I'm just trying to say that you don't start incident reporting if you want it to be a success with the workers. You must start with the leaders and let them know that just culture must be in place, just as well as all the other forms of a safety culture. You know, reporting, learning, and what have you must be in place. So that's just to lend my voice to the issue that it's not a standalone thing. So my comment to the panelists is risk assessment. that's what has not come up all day. And that's the bane, one of the problems I see with us, because our health indices leaves much to be desired on the continent. And one fulcrum that I see that we have not learned, and in Nigeria, in Lagos, where I come from, any assessment that is done, anyone, be it from quality control in-house, be it from assessors, be it from the ministry, be it from the Health Service Commission, one aspect that we don't make high enough marks is risk assessment. If you don't anticipate the risk that this patient will have and put in place those factors that might come up for that surgery to be successful and for complications not to happen, it's going to happen. So, but if I've thought about it beforehand, then I'm going to prepare for it. So, I'm saying this because I know the organizers are going to come up with an end of forum paper, communique of what have you. We must learn risk assessment. We must identify it. We must teach it. We must inculcate that behavior of assessing the risk of our clients. We are learning it. We are not there yet. We score low marks, so it's an emphasis for us. So I'd like to appreciate the team on that.
So, thank you for that. I think maybe two more, and then Ruth Pal, and then I'll distribute the questions to my panelists. Wow. Okay. So we'll have Ethel, and then there's a hand at the back. Okay. Okay. The two hands at the back, the gentleman and the lady. So we'll start with Ethel.
Okay. Thank you for this opportunity. Thank you, panelists, for the enlightening conversation. Dr. Ethel, I work at a facility in Kenya, and my question would go to Dr. Neema. So I'd like to think of myself as a blossoming bud in the quality improvement space. And my question would be, have you gotten to a point in the testing of improvement where you discern that this is no longer working? And at what point do you make that decision? I know we learned something about it during our course, but there's one thing, for example, in my facility that we have really been trying to work on, which is just getting people to use a monitoring chart, and it's not working. And I keep asking myself, is it that we don't have the knowledge as a QI team? At what point, for example, in your experience, do you come to a place and say, okay, this is not working, but then yet again, you've identified that this issue is critical to the system? For us, for example, in a newborn unit, you want the monitoring chart filled and you want it filled well, but it's not working. So in your experience, how do you go about such a circumstance?
Okay, thank you.
Yes, thank you very much. I think mine is a contribution. One on the health systems bit that was mentioned. I think it's a very important bit because a lot of quality improvement initiatives and efforts across the continent have not been sustainable. And oftentimes the sustainability have been because the health systems have been exceedingly or extremely weak, and they have been incapable of supporting the improvements once the sponsors have left. Typical examples are in the areas of human resource and numbers. I mean, sometimes how we even countries, how do you call it? How countries post healthcare workers. Sometimes you know that there is a particular staff in this facility who has this particular competence in quality, and his presence is what is sustaining improvement in that facility. But by the time you realize this person has been posted to another area where his relevance and value is outrightly demeaned and devalued, and the role that he was playing in that initial facility actually gets missing. So it creates a vacuum in a number of the facilities, and these affect sustainability. So I want to say that we should be mindful of the building blocks whenever we are trying to implement or introduce quality improvement initiatives. Other instances are in the areas of consumables. If you say we should implement standards, and the standard requires that after a newborn, you should apply an eye drop, and the eye drop is not available. I mean, then what kinds of standards are we implementing? So this goes to the heart of the building blocks: medicines, vaccines, and technology, human resource, and all the other components. And the other with the incident reporting is, so I dare say that yes, to err is human, but also I feel that some of our colleague healthcare workers sometimes are outrightly reckless. So there is also another provision that we discipline healthcare workers who violate the basic rudiments of care, that we should discipline them. Some of us are very reckless. So, I mean, we should be able to ensure strict accountability and discipline those who violate the basic rules and principles as far as the provision of care is concerned, other than always saying to err is human, to err is human. And we are sometimes, and the point Dr. Tenza makes, that not every healthcare worker goes to the hospital to go and commit errors or other things. We have seen findings show that some providers are very wicked and malicious intent. So patients should also be safeguarded from some of these providers to ensure that they are safe as far as the care they are receiving is concerned.
Thank you.
Thank you.
Thank you very much for the comment. I think there's a final question or comment, and then we go to the online participants, and then I spread out the questions to the panelists.
Good afternoon, everyone. I'm Dr. Matsi from Society for Quality in Healthcare in Nigeria. Thank you very much for this program, first of all. Like everyone has been saying, it's exciting to be here in a room full of leaders and to know that we're trying to move the quality agenda forward in Africa. Thank you very much to the panelists. It was a really good panel session. So my first contribution is a comment to say that, like we're talking about on the table, I think this entire recipe, what we've been talking about basically, is a system approach. We've been looking at everything. Dr. De Kock said something about not working in silos. We've heard everyone talking about this. So I would sum up to say it's a system approach plus psychological safety, but layered with just culture. So I think those are the basic things we've been talking about. Everyone has said it, that we cannot blame the person. We should not blame the person. And I like what, sorry, I'm trying to find his name. Dr. Bernard Omondi, what he said earlier about using a fishbone analysis. So again, like we've discussed here, it's not just about incident reporting. There has to be the investigation. And then you find out what your root cause actually is, and then you implement whatever your solution is. So really good one. System approach, again, would help us with everything. So now to my question. For Dr. Aisha Mohammed, you were talking about standards and about the Health Act in Kenya and about implementing standards. Do you have a central body of standards or standards, requirements, intents that you work with in Kenya to make sure that all hospitals, even if it's just the public hospitals, are on the same page rather. Like for instance, you have maybe accreditation standards or something that everyone is working with, so that if I go to a hospital in Mombasa or I go to somewhere in Narani or wherever, I will get the same standard of care. Thank you.
So as we listen into the questions from the online participants, let me just preempt that we'll have Bernard speak to risk assessment. There was a concern around risk assessment. There's a question on the acts and the politics around the act and the acts and their operationalization. And the question that has just come up in terms of the central body that just works around this quality conversation across facilities. So that will have Dr. Aisha speak to that. And also the involvement of regulators, because I think that's now a macro conversation. Involvement of regulators in the quality conversation, the curriculum. A specific mention was on the Nursing Council, and I think it goes across all the other health worker regulators, as it were. In terms of measuring progress, I know this touches on what Aisha has mentioned, but I think I would also ask Violet to speak to that. So how do we measure progress across this? Incident reporting and preventing repeats. I know Dr. Neema spoke to this, but I think the ball is back to you. Of course, you've mentioned the conversation of a law that protects, but it has come out, I mean, there's still a bit more we can add to that. So how do you prevent repeats beyond just the incident reporting? And then, let's see. Yes, I think those are the ones we'll speak to, but let's see what is online as well.
Thank you very much. Now, before I start, because I'm speaking to my wonderful online audience, who are at the moment 186 of them, I just want to say we are about to break for lunch. When we break for lunch, stay on because we will be replaying the fantastic keynote speech by Ms. Lauren de Kock. So if you missed it earlier on in the day, just stay on and there'll be a replay online as the ones physically go for lunch. So let me now go to their comments. As usual, the online people are full of praise. What a great forum and panelists we've got. Indeed, I agree that the digital platform bringing together 35 counties is quite helpful in cross-pollinating best practices across Kenya. Being an avid user and quality champion, trained and mentored by the University of Maryland and CHEB, Kenya, I must say that continuous quality improvement is changing. So the question is, how do we do things that enhance and enable the client to receive the best quality of services across our science? This is Ondari James. I assume, Violet, this is one of your people. Let me go to somebody. I think Kamagelo Tsunang, I'm not sure what country he's from, but he really related with the example from Dr. Ali about the potassium chloride situation. And he says, the doctor gave an incident of potassium chloride. She reminded me of an incident during resuscitation where a nurse accidentally gave calcium gluconate. Clearly, I'm not medical. Calcium gluconate, and immediately the patient demised. Now, everyone was concerned what actually had happened, and the vial was picked from the sharp container. The nurse was expelled. These are the things that stop people from reporting. So let me go to the final question. The question is, how do you ensure accountability with incident reporting so that you can also address the errors resulting from the negligence? Maybe you can include that in your answer as we go. We are about to break for lunch, so let's keep our responses brief. Thank you.
Okay, thank you very much. I think the aspect of just the accountability, incident reporting, and preventing repeat, I think, Dr. Neema, that now looks like your baby. So we will just leave that to you. So at this point, let me ask that we begin with Dr. Aisha in responding to the set of questions. The mic.
Thank you very much, participants, and especially the online ones, for really being very active and giving us very good questions. So I would start with the regulators, the involvement of the regulators, and I would like to point that when I was making my presentations, I kept on mentioning the joint health inspections. And those joint health inspections, actually, they are called joint because they involve all the regulators in the country. So be it Nursing Council, be it the Pharmacists and Poisons Board, be it the Dentist Council, doctors and Medical Doctors and Dentists Council, all those are actually involved within development of the regulation, checklists, and even the actual assessment for patient safety. So regulators are actually on board. And what was mentioned about if you have malpractice issues. So these are actually then brought to the regulators for onward disciplinary actions. In terms of the having standards at and this body that we have for standards. So we do have standards. I mentioned that at the national level, we have standards that are implemented across the country and all the way down to the facilities. And for quality of care in particular, we have the Kenya Quality Model for Health, which actually has core standards. So those are the standards that we have put on the online platform. It's an electronic tool that now the counties and the health facilities use to assess adherence to those standards and how they can come up with quality improvement projects to improve where they have gaps. We don't have a body as we speak now, but we have a directorate, which our director has just walked in now, Dr. Keegan, Directorate of Health Standards, Quality Assurance, and Regulation. So he's in charge of overseeing all that docket, but we are in the process of trying to see if we can have an independent authority, because we know best practice is actually to have this as an independent function. So we are in the process, that is what I had mentioned, the quality of care bill that we want to work on. We'll actually be addressing some of those things. In terms of the practical approaches of these acts and the standards and the policies that we are having, being a devolved state, being a devolved country, our role is to develop and empower the counties to implement. So we are working with the likes of Violet here to assist us to push this agenda down to the counties, the likes of Dr. Nema in the counties to actually make sure that implementation happens. But we support them in terms of even assisting the counties to look at how do you plan for implementation, looking at the aspects of how do you use even the theories of change framework to make sure that you're planning to implement things based on your data. And even when partners like Violet here come to assist the counties or even the national level, are they meeting our needs as a country and not just coming in with programs that are already far-fetched from somewhere else? So we are working hand in hand to make sure that we deliver the best that we can. Thank you.
I think just before there's, in terms of just operationalizing of the recent laws, any quick comment on that?
So in terms of operationalizing the laws that have been enacted, I must say that there are a bit of challenges. Legally, there are a bit of things that need to be sorted out. But however, in terms of quality of care and how these laws are helping us, and I have mentioned this severally, is that we are tagging for you to be on board some of these government initiatives, then you have to show evidence of your performance to quality of care. How are you on board quality of care initiatives before you can be on board the quality of care, the social health insurance fund, the primary health care fund, because these acts come with funds, they come with money attached to the act. So there's money that are to be given to health facilities, whether you're a private facility or a public facility, both of you are open to draw from that fund, but you have to show evidence of are you conforming and are you complying to certain standards and for quality of care.
Okay, so Violet, you'll pick from there, because there's also a question on measuring progress. So how do we know that you've actually been working on quality, and what progress are you making? So how are you measuring progress? And there was a question on, I think from Ethel, so it's not working. How do we influence behavior change, and how do we learn and learn and relearn? Okay.
So thank you. So I'll start with how do we measure progress in terms of implementation of the policy guidelines? And one of the things that that is in place as a country, we have the certification framework, where once the policy document has been rolled out at the county levels, then assessment is done by the national team together with partners, just to see at what level of certification are you in terms of stars, whether if you are a facility at level 1, Are you now meeting the standards for being accredited to level 2 or level 3? So that is one of the ways that measuring progress of implementation is done. In terms of CQI projects, because it has to be evidence-based to show where were the gaps, what was done, and can we be able to see. So one of the things that we are having still a round table with the Ministry of Health just to ensure that this CQI digital platform is now fully adopted by the Ministry of Health, is to be able to track the initiatives on the platform, and you can be able to evidently demonstrate that this is where we were from the beginning and this is where we are currently. And I think somebody online asked in terms of number of facilities that are currently using the platform. I may not have the exact figure, but I know all the facilities that have an MFL code have the right to utilize the CQI platform, and currently we have over 2,000 users that have rights to be able to use as managers, and then at facility level there are even more than 3,000. So all facilities with an MFL code within the country aligned to the KHIS organizational tree have a right to utilize the digital platform. I don't know whether there's any other in terms of I think it was Dr. Nema, but I can just chip in terms of you have implemented a CQI project for some time and then it is not working. At what point do you pick or do you now say, can I make a decision of whether to drop because it is not working or not? I think being a room with experts, we have CQI tools that will be able to help you to determine, to know that this intervention is working or not working, and one of them is the run chart that you can be able to visualize and see and be able to determine that this is actually working towards my objective or it is not working. And it is not a crime if an intervention did not work. You learn lessons from what did not work, and then you can be able now to reevaluate and pick on something else. Thank you.
Yes,
Thank you, Violet. Thank you, Violet, for that clarification. I would also say that I think it's working. Yes. Oh, I can't hear myself. Okay. In addition to what Violet has said, I would also go back to the drawing board if that particular intervention didn't work, and perhaps also consider involving the entire team, the stakeholders. For example, in your particular situation, the stakeholders that are involved in charting of the newborn chart, who are they? They need to be involved right from the beginning. And also their tech matters. Why is it not working for us? As you do a root cause analysis, you ask them, well, are there factors, maybe people factors, place factors, procedures, policies that are hindering you from doing this documentation? And from their inputs, you can be able to come up with a root cause analysis, which then you will develop your countermeasures. Now, it is those countermeasures that you keep testing and seeing whether they are having a positive impact on your run chart or not. And when they do not work, you go back to the drawing board, because that is an important project that you're undertaking, and you don't drop it. You continue with it. Remember, Einstein didn't get it at the first time. He failed so many times before he got it right. So don't lose hope. Don't abandon. Please don't abandon. Just go back to the drawing board, consult widely, try another strategy. That would be my advice on that. In terms of incidents reporting, my God, I seem to have touched some very sensitive wires. Thank you for your inputs. It is true. It doesn't just start with reporting. It's not just about reporting. There's a lot at stake around that reporting. And for us as a county, we haven't been doing well in terms of incidents reporting, and where we've agreed to start through public and private collaboration, we have agreed to just start sensitizing our teams so that they have a heightened awareness of incidences and reporting. We're not even asking them yet, please mandatorily report, because they still don't have that psychological safety that we want them to have. But again, additionally to that, we are conducting a survey, a very small survey, an anonymous one, of course with Google Forms again. And we want to see what is the attitude of the healthcare workers in terms of incidents reporting. And remember, incidents is not just an error. It can be anything, a fall from a bed. It can be an oxygen cylinder that wasn't able to deliver the oxygen, anything at all. And even if you report an oxygen cylinder that wasn't able to deliver oxygen, there is no action that anyone can take on you negatively. But why aren't we reporting? Yeah. So we want to look at those hindrances. Why wouldn't you? Are you reporting? And if you aren't, what are the things that are making you not to report? We want to start. We are starting from there. And even as a county with the privates on board, we want to come up with that law that protects our healthcare workers. And we feel like also this survey will help also with the leadership advocacy, because advocacy has to start at leadership level. And we don't advocate without data. That is why we agreed, let us do a survey and see what are the feelings of our healthcare workers in terms of reporting any incidents, yeah, including the errors. And so, yes, that is where we're starting small, but we are hoping that maybe by the end of the financial year, that is by June, we'll have at least achieved some milestones in terms of making some changes towards that. How do you ensure accountability in medical error reporting? Oh, that's a hard one. Remember, in most of or some of our facilities, we have someone working alone, maybe in a shift. That is the reality sometimes. And for you to say even it's mandatory to report, there might be an error, an incident, but this healthcare worker might choose just not to report. It is a goodwill. It is a goodwill where we just need to encourage, thank them, praise them for bringing this up, because these are all learning points, learning opportunities. For each incident, it is a learning opportunity. So we just need to approach it in a friendly way rather than an authoritative way, so that we can just open up slowly. I know it will take time. It's not something we can achieve in just, a year, but at least within that we need to put the necessary measures to make people comfortable and highly aware of this, and make it like a theme across, yeah. So I don't know if there's any I've left out.
I think we are safe there.
Yeah.
For now.
Thank you.
So that they don't rise up in uproar because of lunch. But thank you very much. Let's allow Bernard just a few minutes to speak to the comment on risk assessment as well, and then we will wind up.
Thank you. I really appreciate the discussion. Just before I talk about risk, just one idea about incident reporting that has helped us. We are not there yet. It's something we are still struggling with. But one idea that has served as an encouragement is use incident reporting as a tool for training needs analysis. When you collect those incidents that have been reported and you perhaps identify a gap that maybe skill needs to be improved, then organize for a training to address that particular area. When you do that, people feel encouraged. People feel that if this is where we were all lacking, and it seems to be happening elsewhere within the institution, then they can actually appreciate the need to report, so that a training, an improvement, a skill check can be arranged to add on to what they already know, so that they can prevent that thing from happening again. But now talking about risk and risk management, most organizations have different ways to approach the subject. For us, it has been the accreditation. the hospital is COSASA accredited, and one of the requirements is risk assessment. Most organizations go through the ERM, Enterprise Risk Management. Some organizations also use certification, ISO certification, and different ISO standards require risk assessment as one of the needs in order for you to get certified. But in a very basic way, so that we can end the session, risk will involve starting from risk metrics, which is determined by the organization, that for us, this is what we'll use. So you come up with a risk matrix that will be used for the organization and then given to the different departments. Then go through the 6 mandatory steps. Identify the risk, analyze the risk, rate the risk, determine the risk treatment, risk monitoring, and then risk review. Once you're able to look at all those different areas, then you can arrive at what works best for the institution. And one encouragement that we give every department, every section, every process owner, is that risk assessment is a team effort. So you put the entire team together, use different tools that are available, get them through, going through, let's say the easiest one is process approach. Look at your processes, and at every process step, identify what it is that can go wrong. Where are we likely to face a hiccup? Use that as a starting point in order to develop an institution-wide risk register, which will then help you in managing your risks and knowing, because one of the things that we tell them is, forewarned is forearmed. Once you know, you are able to put control measures, identify mitigation measures to manage the risks that are in existence. Let me stop there. Thank you.
So a better, I know we are short or low on glucose, but a better round of applause to the team. And thank you for the emphasis, because from the conversation we can clearly see that quality is not just a service component. There's a lot that is required, and it has to start from leadership, yeah? And it has to go across all levels, from the bedside to the boardroom, and across from the policy level to the facility level, and even to the community level, which then rightfully goes into the households. There's a lot more. I think the conveners now know that the topics will need more time. So food for other conversations and more convenings like this. But with that, I'd like to ask that we again give my panelists a warm round of applause.
Thank you very much to our wonderful second moderator of the second session. You have done a good job, Mike. Now, as you're taking photos, please proceed. I want to invite, each panel takes a photo right here in front. So I want to make sure I invite Chris Mandera, Nora, and Edna, who missed their photo, so that they take it. Lunch is where, Shiro? Where is lunch? It's on the second floor. So use the lift, go down to the second floor, and actually you'll just see, it's on this side. So everyone is welcome to have lunch. There's a voucher at the door as you get out. We will do our best to manage the time so that we end on time. We are very glad to see that our opening ceremony will happen right after lunch. Now let's have a conversation about time. Can we all be in the room before 3 o'clock? So 2:59. So we will start the next session at 2:59. Bon appetit, have a wonderful lunch session.